Good evening, everybody, and welcome to the Alexander Janssen's Myocarditis Information Evening. As you all know, we are focusing just on COVID and the vaccines tonight. We've got our guest speakers, Professor Prasad is here, and we've got Doctors Mamina Yazadi and Alma Iyakub that are going to be chatting to us tonight. We will have an opportunity at the end of the evening for a Q&A, but could I just ask for the duration while the speakers are speaking that everybody just mutes themselves. When we open it up to the floor, take yourself off mute, ask a question, and then we'll do our best to answer. If for whatever reason you don't want to ask the question yourself, please just pop it into the chat and I am more than happy to ask the question on your behalf. So Sanjay, are you ready?
Thank you, yes. Great, so I'm just going to share my screen and then we'll be able to start. Are you able to see my slides? Sarah, can you see my slides?
Yes, I am. Yes, I can. Thanks.
Lovely. Thank you very much. So first of all, thank you and welcome to everyone. We're really grateful to you for joining. The purpose of this evening, as Sarah and Andy have said, is that this is very much an opportunity to ask questions, hopefully gain some insights. And we'll start off by two directions, really. One is just a quick update for what is COVID, how does it affect the heart, what is long COVID, and then we'll move a little bit on to inflammation and a little bit on vaccination and how that has affected the heart, and then we'll really open it up to questions. Both of these talks will be relatively short, so I'll try and keep mine to no more than about 10 minutes or so, and then that way everyone can ask their questions. Great, so long COVID and the heart. So during this, we'll talk about how does COVID affect the heart, how do patients present, if you went to see your GP or someone in hospital, what sort of tests would come up, treatment strategies and red flags. And I think this really forms an important basis, because although we'll talk about vaccination, the role of vaccination is twofold. One is, what is it preventing? And secondly, a big issue for many of our patients is not so much should they or should they not get the vaccine, but how have they personally been affected by COVID? And again, you're all aware, you just have to look at the news that we've been through a number of surges. So clearly the big one was last year, but then again, even in this year, we were seeing surges November, January, and then there's a mini surge that's just occurring just at the moment. So I'm reminded of this quote by Winston Churchill. So now is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. And as we start to see our way through, as lockdown has eased, as people are becoming more mobile, through vaccination, through people wearing masks, etc., we are starting to see reductions in numbers. We're not there yet. So it's an exciting time in terms of having dealt with COVID. Last year, around March, April time, was just a horrible, horrible time in terms of the number of patients that we were seeing. So thankfully, we're not seeing anything like that, but we must remain vigilant. Again, a very quick reminder, one of the key impacts of COVID has been inflammation of the heart, myocarditis. And as a reminder, myo means muscle, card, heart, and itis, inflammation. So we're looking at inflammation of the heart. And again, there are a whole number of causes that can cause myocarditis. It's not just due to COVID. Viruses happen to be one of the commonest causes, but there are other things, drugs, toxins, radiation therapy, that can also cause it. So in terms of COVID, before the pandemic, I think it would be fair to say that we were really concerned that we were going to see a massive surge in the number of patients presenting with heart problems, particularly due to inflammation, due to their myocarditis. We know that in previous flu pandemics, lots of patients have presented, they've been really ill. And one thing that was reassuring is the wrong word, but better than we expected, was that those numbers just didn't come through. Thankfully, there wasn't that massive surge of heart failure or of heart disease or of myocarditis following COVID. It clearly had lots of other ramifications, but a lot of the issues that occurred were much more respiratory driven, and then the smaller percentage was respiratory with some heart involvement, and direct myocardial damage, as you'll see in this figure from one study, was 7% as the primary cause of death. Of course, many of these patients will have had involvement in many organs, but the primary cause and the thing that really caused the issues was very much due to that. Can you see my slides? Sarah?
So Sanjay, they're not changing. We're still on the first slide.
Oh, I'm so sorry. Let me find out what's going on. I will come off slide. Let me try and just do that again. I'll try and reshare again. How about now? Can you see the slides?
Yes, we can see that. We're looking at a pie graph at the moment.
Exactly, yeah.
Okay,
and if I click next, are you seeing the next slide now?
yes, we are.
Okay, good. So coming back to, please do let me know if the slides don't move. So this one should be myocarditis and the C word, so COVID. So thankfully, from the heart perspective, we weren't seeing that massive surge that we were expecting. But undoubtedly, and as you're only all too well aware, lung issues were a massive issue. So respiratory failure was probably the commonest cause by far of death during the acute COVID illness. And why were patients presenting with any form of injury? Well, there are a number of different reasons. And although this is a busy slide, and again, hopefully you can see itself, is directly causing inflammation of the heart. Secondly, it's causing inflammation of the blood vessels that line the heart. So these blood vessels suddenly block up, they cause a heart attack and a rupture. So that can be another issue. And then the other reasons are that they develop sepsis, so generalized inflammation in the body, and these generalized inflammatory markers then attack the heart muscle. And then finally, another common cause is that they're getting, or final two common, they're developing changes, clots, build up of pressure in the lungs, and so the heart's having to work much harder. So that is another common cause. And then they're getting supply-demand mismatch because the body's having to work so much harder, the heart's getting to overdrive, direct hit on the heart muscle. It causes blockage of the small blood vessels in the body, as well as the big blood vessels supplying the heart. So microangiopathy, disease of the very small vessels where they form many clots in the blood vessels, but also causing changes through that way.
Sanjay, we seem to have lost you. Sanjay? Hang on.
He's on mute.
Yeah. Sanjay, if you can hear us, you put yourself on mute. Sanjay, if you can hear me, there we go. You're off mute.
Yeah, no, I'm not sure why that happened. But so one of the things that we've realized is that some months after the initial presentation, patients are then presenting with the long-term sequelae. So, and can you see my slides? Sorry.
No, not at the moment.
Okay.
We seem to be plagued by technical issues tonight.
The joys of Zoom. Right. Let me know when you can see it.
Sanjay? for some reason, when you use the slides, your sound goes warped on our side.
Is that coming up now?
Yes, we can see your
Yep.
slides, but
You can turn your camera off, Sanjay.
you might need to turn your camera off, because when you have your slides on, the sound is going a bit funny.
Okay. All right, let's do that. Right, let me know when you can see the slides.
Yeah, that's much better.
That's much better. We can hear you properly and see the slides.
Okay, perfect. My apologies. So some months after the initial presentation, we were seeing a lot of patients presenting with persistent sequelae from the COVID infection. They were getting palpitations of fast heart rate, shortness of breath, they were getting chest pain. And when we look at the hearts of these patients in a subset, not all of them, we are picking up these big fast heart rhythms, we're picking up scarring, we're picking up many heart attacks, and it highlighted the fact that there is a subset, and thankfully the minority, but a subset that need to remain under close follow-up. So that's then resulted in this definition of long COVID, which is really beyond the initial month. So after about 4 weeks from the acute infection, when symptoms are still persistent, and then that's further divided into the sort of chronic long COVID, which is the persistent symptoms after about 12 months after an acute COVID infection. And that's been a real challenge now, because these patients are presenting with shortness of breath, they're presenting with chest pain, they're presenting with tightness. And so we described how there was the initial presentation, that inflammation of the heart, the lung issues, the problem with blood clots forming, the problem with sepsis that have continued to cause issues even long after the acute infection has subsided. So patients, as I say, present with chest pain, they present with tightness, palpitations, very breathless, and often very fatigued as well. And different to the acute presentation, again, much of this, the virus has gone off, but this is very much the immune system going into overdrive. So this is less that there are lots of other changes that are occurring.
Sanjay, we've lost you.
They're often getting a persistent cough. We talked about the chest pain, their risk of getting kidney issues, muscle wasting and weakness and deconditioning and hair loss. So these are all things that have to be recognized. So how common is it? Well, again, we're still building up our database on this. The group that are hospitalized, when people have done surveys of patients that have been hospitalized with COVID, we're seeing numbers around 20 to 30% that have some degree of persistent symptoms. Again, thankfully, the majority are relatively mild, but in some, it can be quite severe breathlessness that's persisted, including with fatigue. Again, when we look at Wuhan, the data from China, where they've probably got the longest series now of patients at 6 months, in patients that were hospitalized, 76% were reporting at least one symptom, fatigue or weakness being the commonest, sleep difficulties, and anxiety or depression. So again, it's a lingering sequelae that we need to be aware of. And chest pain seen in about 5 to 20%, palpitations, that fast heart rhythm in about 10% of patients. So who are the patients that we are most concerned about, that we think are at greatest risk? It's really those that are older, those that have existing lung disease, those that have high blood pressure, and with kidney disease. So those are the ones that we really focus on. And in terms of our workup, what we really do for these patients is think about it, a number of heart tests, looking at the scans, ECGs, looking at that side of things, and the treatment is really targeted towards what's going on. So my final comments really, where they're getting those symptoms, if there's direct heart injury, we can think about treatment to slow the heart rate down. If they're very fatigued, we give a graduated rehabilitation program, if they're getting dizziness, again, lots of fluid, and thankfully the majority of patients will respond and improve by about 6 months after that phase. Thank you.
Thank you very much, Sanjay. I'm sorry that we couldn't watch all the slides. We just seem to be having a bit of a connection issue. But we are going to hand over to Alma, and she's also got some slides up, and she's going to take us through the rest of it, and then we'll be opening up to the floor for questions. Sorry, Alma's having a few technical issues with getting her slides up. In the meantime, are there any questions based on what Sanjay was saying that anybody would like to ask? Sanjay, I've got a question that's come through in the chat. Can you said at the end there that most people seem to make a recovery within 6 months. Will they be, during those 6 months, will people or should people still be under the care of a cardiologist?
It really comes down to what symptoms they're getting. So if they're getting persistent chest pain, lots of palpitations, breathlessness, then yes, definitely. Whereas if the symptoms are just mild and intermittent episodic, then they're not necessary.
Okay, I think Alma is up and running, so we will move on with Alma's slides. Thanks, Alma.
Yeah. This is a very just a second. Yeah.
I just say we can't hear you.
That's why, because I knew to. So sorry, starting again. This very factual presentation on the COVID vaccines and the link to myocarditis. So as we said before, myocarditis is an inflammatory condition of the heart. Its incidence, or how frequently it occurs, is difficult to establish. And that's because most cases are mild, they're not well investigated, and they're not reliably reported. And I was saying that the Alexander Janssen's Myocarditis UK supported some recent research into this topic. And this research was recently published and has been used by Public Health England in issuing some of their advice. And it was found that between 1998 and 2017, there were about 36.5 per 100,000 people, 100,000 NHS admissions with myocarditis. And from the same source in 2017, there were about 2,000 hospital admissions with this condition, with myocarditis. As we know, majority of these cases were in men, so 2/3 of cases were in men, and men were significantly younger at presentation compared to women, with a median age, so the most commonly encountered age of presentation being 33. There are many causes of myocarditis, And I suppose, so they include infection, drugs, toxins, but the most common cause of myocarditis is a viral infection, and that causes an acute lymphocytic myocarditis in terms of the kind of pathological term for it. The presentation of myocarditis is very variable, and it resembles a lot of other conditions that affect the heart and the lungs. So it's not a very specific presentation, but it includes symptoms like chest pain, shortness of breath, palpitations, and fatigue. Luckily, most patients respond well to standard treatment, and they make a good recovery with good prognosis. However, there's a small subset of patients that are very severely affected by myocarditis. And these patients can progress to something called dilated cardiomyopathy, which is where the heart becomes enlarged and its strength decreases, and they develop chronic heart failure. And there is evidence that in about 12% of sudden deaths in adults under the age of 40, the cause has been myocarditis. And now to the topic of COVID vaccinations and myocarditis. So, is there an association of myocarditis or pericarditis following COVID-19 vaccination? And the short answer is there appears to be. So there has been a signal of an increase in the number of cases of myocarditis and pericarditis following the use of mRNA vaccines. So these are the Pfizer, BioNTech, and Moderna vaccines. And these are some very dry numbers, but I think they are useful to just put things in perspective. So in the United States, until June of this year, there have been about 300 million doses of mRNA vaccines administered, and there have been 1,226 reports of myocarditis. A majority of these, a vast majority, 923, are in males with a median age of 26. The median time to onset of symptoms is 3 days after the vaccination, and most of these cases of myocarditis occur after the second dose. Similarly, in Israel, they've administered 5 million first doses and similarly 5 million second doses of mRNA vaccines, and they have had 148 reports of myocarditis around the time of vaccination. And the findings are similar, with a higher incidence in younger males, and most cases reported after the second dose, the second vaccination. In the UK, we have had 149 reports of myocarditis and 129 reports of pericarditis following the Pfizer vaccine. Some of them, some cases of myocarditis, about 82, following the AstraZeneca vaccine, and 25 cases of myocarditis following the Moderna vaccine. So in terms of the overall rates, for the Pfizer BioNTech, there are 4.3 cases of myocarditis per million doses administered. And with AstraZeneca, the incidence is much lower, 1.7, and with Moderna, the incidence appears to be higher, the highest at 14.7 cases of myocarditis per million doses. I think interestingly, it appears that the consensus is that given the extensive use of the AstraZeneca vaccine in the UK program, the cases of myocarditis reported with this vaccine are thought to actually reflect the background rate of these conditions. So it's not necessarily thought that these cases are necessarily caused by the AstraZeneca vaccine, because they are not higher in number than what you would expect to occur normally. And what is the outcome of patients with myocarditis following COVID-19 vaccination? Most patients respond well to standard treatment, and they have a good prognosis. However, I think it's good to keep in mind that we don't know what the long-term consequences are of these patients that do develop myocarditis, and studies are still in progress to determine these consequences, with follow-up at 3 months and 6 months. Some practical questions and guidance. So if a patient has had myocarditis or pericarditis following the first COVID vaccination, should they have a second dose? The official guidelines from the UK are as follows. So these patients should be assessed by an appropriate clinician to firstly determine whether the myocarditis or pericarditis is vaccine related. Then secondly, it's advised that a blood sample is taken to test for antibodies to SARS-CoV-2. And there are two reasons for taking this blood test. One is to determine if the patient has had previous COVID-19 infection, and depending on the level of their immunity, is there a need for a second dose of vaccine in the first place. At the moment, we don't really understand the mechanism of how myocarditis occurs after these vaccines, and therefore the advice that a second dose should be deferred until further information becomes available. However, the guidance also says that a second dose of the Pfizer vaccine can be considered once the patient has fully recovered. And I suspect that this is where the risk-benefit discussion would come into place for each individual patient. Again, emerging evidence suggests that an interval of at least 12 weeks should be observed. And if there would be a second dose of a vaccine given, that should be Pfizer over Moderna, as there is a higher incidence of myocarditis reported with the Moderna vaccine, as I showed on a previous slide. And AstraZeneca shouldn't be offered to those who have previously received an mRNA vaccine. So should someone who has had myocarditis or pericarditis previously have a COVID-19 vaccination? Again, very important, the risks and benefits should be discussed on an individual basis. However, this is not in itself an absolute contraindication to receiving a COVID-19 vaccine. So previous history of myocarditis or pericarditis is not in itself a contraindication, but I think each case is unique and should probably be discussed. And I've put these references up, which I think are useful. The first two from Public Health England Green Book, which is a very detailed guidance on COVID in general and then vaccination. And the second link is similar information, but in a more succinct form. And thirdly is the research that I mentioned that was supported partly by the Janssen Foundation on the epidemiology of myocarditis in the UK. That's it.
Thank you very much, Alma. There are a few questions in the chat, which the first one that we had, Sanjay or Alma, I'm not sure who of you wants to ask this, but the first question that we had is, what is the standard treatment for myocarditis?
Do you want me to take that? So it depends on how severe it is. So if it's very mild and patients have very little in the way of symptoms, you may just take a conservative approach and watch. However, if patients have had a very high troponin rise, in other words, a lot of inflammation, if there's any suggestion of the heart being of the heart function being reduced, if there's any suggestion that the lining around the heart is also affected, then the standard range of drugs would include colchicine to try and reduce some of the inflammation. You'd use paracetamol for some pain control. In the old days, we used to use Brufen a lot, but the current thinking is that that can dampen down some of the inflammation if the main problem is in the heart. But if it's affecting the lining around the heart, called the pericardium, then we would also use a drug like a Brufen or like drugs like Brufen or Voltron, which are what we call non-steroidal drugs. And then if the function is down, then we would think about a beta blocker and a drug called an ACE inhibitor, ramipril, perindopril, drugs like that. And the beta blocker slows the heart rate down. It gives it more time to recover. It helps to reduce inflammation. The drugs like ACE inhibitors, ramipril, act in a different way and help to support and improve function. So for the majority of patients, thankfully they present with mild symptoms, a little bit of inflammation, but heart function is fine. And in those patients, maybe a course of colchicine would be adequate. But where there's any suggestion of heart damage, then on top of that, we would think about introducing a beta blocker, introducing a drug, as I said, the ACE inhibitor.
Thanks, Sanjay. And then the next question that I've got here is, what are the treatments for chest pain? I've been put on beta blockers, but it has only made a slight difference. I've been to A&E twice with chest pain. Twice with chest pain and palpitations since echo diagnosis, but get sent home every time.
Again, respectfully, we can only give general guidance rather than specific, but allowing for that, I guess the key question is, why is there chest pain? Is that chest pain because inflammation is ongoing? Is that chest pain because the lining around the heart rather than the muscle itself has become inflamed? Is that chest pain because of a lung issue, let's say something unrelated to the heart, or the chest wall lining, all of which can be affected by a virus or COVID. So if it is coming from the heart muscle or the lining around the heart, the question to ask is there active inflammation? Blood tests and ECG, occasionally an MRI scan of the heart, would be really useful here to give that information. And then standard drugs, if it's coming from the heart, on top of the beta blocker, would be drugs like colchicine, which help to suppress some of the inflammation and help to ease the pain. But the starting point would be an ECG, a blood test for troponin, and thinking about an MRI scan of the heart in the presence of persistent symptoms to really get to the root cause of what's going on, and then dealing with that. I hope that answers the question. Happy to elaborate on that if anything's unclear. So please just ask and just say if anything doesn't make sense.
Right. Thanks, Sanjay. Catherine, can you unmute yourself, please?
Hi.
Hi.
So I have two questions. I typed them already on the chat, but it's quicker this way. I have two questions. If I may ask two, it's okay?
Yes, you can.
Okay, thank you. The first one is for patients with myocarditis. In my case, was post-COVID, not post-vaccine. After the 6 months, if the patient still have random symptoms, let's say like chest pain and difficulty to breathe, etc., all the heart attack-like symptoms, what that patient can expect for the future? I mean, it is okay within the first 12 months, year and a half, to still have those symptoms even though the recovery is going, or does that mean that patient is gonna end up with a dilated myocarditis, for example? And
Sure.
my second question, okay, you can ask that one. It's okay, thank you.
Maybe, so I'll give you my views and then I'll bring in Alma and Mamina. So again, it comes down to the root cause of what's going on. So is there active inflammation? Is there scarring in the heart, or is there inflammation of the lining around the heart? So if there's active inflammation in the heart, then we would expect that to decrease over time and symptoms to improve. If there is scarring in the heart and that's causing irritability, or inflammation of the lining around the heart, then again, thinking about targeted treatment for those becomes important. The expectation is still that those symptoms should improve. And again, drugs like colchicine, like beta blockers, ACE inhibitors should help in that. But it really comes down to knowing what's causing those ongoing symptoms. Alma, do you want to add to that?
Yes, no, I agree. And I think luckily we have many ways of assessing the heart and exploring a lot of these symptoms, and through tests like an ECG or an echocardiogram or an MRI, we can assess inflammation and the heart function in a lot of detail. And I think if these tests are normal, that can be very reassuring. That is not to say that the symptoms could not continue. That could happen, but as Professor Prasad was saying, it's important to exclude ongoing inflammation as the cause for the symptoms. And I think you also asked, what is the likelihood after 6 months of developing dilated cardiomyopathy if you still have ongoing symptoms? Again, yes, all the tests that Professor Prasad and we have mentioned here are very good at assessing the function and the size of the heart and the presence of inflammation. And I think this is what's actually required to determine whether there is any sign of developing dilated cardiomyopathy or not.
Okay, perfect. Thank you. And my second question was about the vaccine.
To add to that, Catherine.
Yes.
Sorry, Catherine, just to add there, if by 6 months you haven't had a cardiomyopathy, the risk of developing it certainly when we've looked at our cohort, is very small. It's not zero, but generally the bulk of the hit tends to be early on. So if you've made it to 6 months without the problem, that doesn't mean it won't occur. I'm more reassuring that you're unlikely to get it.
Thank you so much. I appreciate it. And my second question was about the vaccine. What do we know about myocarditis post-vaccine in patients who already have myocarditis? If we have any information, I understand it's a very new topic. And thank you.
I am not aware of specific research into this topic. I think, as I said, the guidance is that in general, a previous diagnosis of myocarditis does not necessarily mean that you would develop myocarditis following one of the vaccines. However, I think each case is very individual, because I think if someone has had myocarditis very recently and there is ongoing inflammation, I think the discussion would be very different from someone who has had myocarditis many years ago and has fully recovered. So I think it should be an individualized discussion with a specialist, ideally.
It makes sense. Thank you.
To add to that, Catherine, when we've looked at our own series, so we looked at all of our heart patients, not just myocarditis, but those with other forms of heart issues as well, where they can get inflammation. And thankfully, the burden was very low. So it's not that it's zero, but I can't think of a single one of our previous myocarditis patients that's developed a recurrence after the vaccine. But at the moment, within our own series, the number is very low.
Thank you.
Sanjay, I've got another question here. Just saying, generally speaking, is a COVID vaccine recommended for patients with current active heart inflammation?
So if they have active heart inflammation, in other words, if they've got acute myocarditis, let's say at the moment, then what Public Health England is recommending, and we've had a few patients like this, is to wait a little bit of time for that active inflammatory process to subside, wait for the marker of heart inflammation called troponin to come down, make sure the ECG is okay, and then to give it. So usually to delay by something like 6 weeks or so. And again, it's very much an individualized discussion, but the guidance is along those lines, and generally to go in favor of, let's say, the Pfizer rather than some of the other.
And then lastly, the other question that's there is it possible to have inflammation without raised troponin levels and a normal ECG?
So troponin is a very sensitive marker of inflammation, and it's pretty specific for the heart. So the answer is yes, it is possible. In as much as you can have very low level, but troponin is such a sensitive marker that pretty much, if it's normal, that indicates one of three things really. One is that the level of inflammation is very, very mild, and therefore not at a resolution where clinically we would expect it to be significant. Two is to think about something else as the cause for symptoms. And third is that there may be inflammation of the lining around the heart called the pericardium, and that can also be a cause of chest pain. So if symptoms are persistent, it's worth just thinking about, could this be around the heart rather than the heart itself? And again, wherever symptoms are persistent, it's especially as our learning increases and as we see more. But if it's coming from the heart and the troponin is normal, the ECG is normal, then patients are in a very good prognostic group. They do well, and it's much more difficult to think about what's going to make a difference from a treatment.
Thank you, Sanjay. Sanjay, I do have some questions that people wrote into me this morning that if I can ask you quickly. So the first question that I've got here reads, with all the indicators showing that myocarditis and the vaccine seems to be prevalent in young men and possibly causing a spike or a rise in with myocarditis in young men, is it still advisable to vaccinate my 16 and 17-year-old sons?
Yeah, so again, this is a super important question. And the evidence is that you're something like six times more likely to get a major complication because of COVID itself than because of the vaccine. So the answer is very, again, I don't wish to take a political stance, and I appreciate different people have different views on this, but from a factual, objective perspective, given that risk benefit, the risk is very much outweighed by the benefit. And we are seeing surges of myocarditis in younger people as they're socializing and as they're mixing more and integrating. So the evidence is very much more in favor of getting the vaccine than not being vaccinated.
Thank you, Sanjay. And then I've got the last question from me, unless there's something from anybody else. I have a question here that says, I have had numerous ECGs and echoes, still experiencing severe chest pain, have been to A&E a number of times. Surely by now I should be offered an MRI. Is that something the patient can push for?
Yeah, so I think, again, one can only give general advice at the moment, but in someone that presented like that, the things that we would be thinking about, and again I'll bring Alma in a moment, but if we were to see a patient, they've got severe chest pain and the ECG is normal, I'd be thinking about doing an MRI scan. And the reason for doing an MRI scan is that it gives very high resolution images of what's happening to the heart in terms of function, in terms of any scarring, and importantly, in terms of any active inflammation. So the suggestion there would be to have a word with your cardiologist and say, please, can you be referred for a cardiac MRI scan to look for active inflammation? And then the other question would be whether things like coronary artery disease needs to be excluded. It's unlikely if the ECG and the troponins are all normal. But again, one would be thinking, is that something that needs to be considered as well? But an MRI scan would be the starting point. Alma, would you add anything else to that?
No, I agree. I think being seen by a specialist and starting from the very basics of taking a very good story of the pain and when it occurs, what makes it worse, what makes it better, and then targeting the investigations accordingly and exploring the causes of pain, the heart causes of pain, as Professor Prasad mentioned, and then not to forget that there are other causes of chest pain that are not the heart. And all of this is very important to explore in a kind of very systematic and thorough way. And sometimes, being seen by the right person at the right time, in the right context, is key to that, I think.
Can I just add to that? Thanks for that question. I think the only thing I would add is just a logistical point. I think the question said that they'd gone to A&E with the chest pain. Yeah. And sometimes, or often we find that in A&E they can't order some of these tests. And so, as Sanjay and Alma mentioned, being seen by specialists may be helpful because things like a cardiac MRI or further investigations can often really be ordered by a cardiologist or a specialist. So maybe that's
just on that note. For somebody in that situation, how do they request an appointment with the cardiologist?
Well, often it's a referral by the GP. In some hospitals, A&E may be able to refer them to certain clinics. we know that there are waiting lists. So I would say if they are having persistent symptoms and they're worried about them, going to A&E is appropriate, but for long-term follow-up or referral to a cardiologist via a GP is something worth seeking.
I think it depends on the country as well. I know we have members from all over the world.
This is England, this is
So
NHS.
in
this
the
particular
UK,
question
for
is
example, there's
NHS.
two chest pain clinics which have a reasonably short waiting time. Depends on the place, but they are not very long waiting times as far as I know, because they're designed to assess patients with recurrent, ongoing chest pain. So the mindset and the purpose of A&E is to exclude, the immediately life-threatening conditions like a heart attack, acute myocarditis, for example, that would show in an abnormal ECG or troponin. But beyond that, I think a referral sounds like.
And it's, if I may just add that again, one can fully understand the frustration of having ongoing symptoms. So definitely an MRI scan is the starting point. What's very difficult from a medical perspective is what do you do if the MRI scan comes back and it's completely normal, because then the patient is left with the symptoms and we don't necessarily have a clear steer on what's going on. So that's when it becomes challenging, and that's when you have to dig deeper, look for other causes that could be driving it, and sometimes you recourse to giving analgesics as the mainstay without necessarily having a clear handle on what's causing it. There's about 30 or 40 different causes, and some of them can be quite variable and intermittent and random. But at least you exclude the dangerous and the common and the more directly treatable, which is probably the key initial objective.
Both A&E and GPs in the UK, I think, can refer to the chest pain clinics.
Okay, thank you very much. Can I just say to Galaxy, I hope you can hear me. You've sent me a message which is personal for my eyes only. I can't actually open it during the meeting because everybody will see it. But when we've all logged off, I will run your question past Professor Sanjay and come back to you with a reply. If I could ask you to just send me your email address in the chat, and I will get you the answers to your questions by email. Thank you. Does anybody else have any further questions that they'd like to ask?
Hello, yes. I wonder if I can, please. Good evening
Yes,
to
of
you all.
course. We can hear you.
Can you hear me okay, yeah?
Yes, we can.
Loud and clear.
That's lovely. Thank you so much. I had myocarditis 12 months ago, which resulted in LVSD. And I've had 2 AstraZeneca vaccines with no problem at all. Do you think, is there a preferred booster vaccine that I should request, or do you think you were talking about the Pfizer being more preferable to patients who've had myocarditis? I was just wondering your view.
I think at the moment booster is done with the Pfizer. The specific guidance is that one should not have an AstraZeneca vaccine after having had a Pfizer vaccine, but given you've had the AstraZeneca to start with, I don't think that's a concern in your case. But the boosters are currently done with the Pfizer vaccines.
Okay, thank you. Thanks.
Do we have any other questions from anybody else?
I'll just add another thing that's very contentious that a lot of our patients ask, and therefore I raise it, is what do you do with kids? And one thing we see is that everyone is very, very happy to have the vaccine themselves. But then when your school contacts you or the local health authority contacts you and says, we would like vaccines for your children, we'd like to vaccinate your children, that's a whole new ballpark. And at the moment, the evidence is very much, again, very in favor of that vaccination, but it's not something that one takes lightly. And I'm sure we will see a widening campaign to target younger and younger children. But the most recent evidence that was published a few weeks ago showed that even young children can be at risk. It's a much lower risk than adults. But again, the evidence was very much the evidence demonstrated that those that are vaccinated have a lower complication rate than those that aren't vaccinated. So that's just something to think through as well, because that's super contentious at the moment.
Perfect. Thank you very much, Sanjay. If there are no further questions, then I would thank all of you for joining us tonight. We really hope that our evening was informative, that we provided you with some of the answers that you've been needing or looking for. This has been recorded tonight and will be available on the website by Friday. So if there were any questions that there was quite a lot of information, and if you want to go back on it, it will be available on our website, that you can go back and have a look and listen to the answers. But then if there's nothing else from the Alexander Janssens charity, I will thank you all very much for coming. And thank you very much, Sanjay, Alma, and Romina for joining us tonight.
Thank you.
Thank you. Thank you.
Thank you.